Good morning, everyone. I would like to thank Purish sir and Amish sir for giving me this opportunity. So, today we are going to discuss mainly four different trials, starting from keynote CheckMate 816, Niagara, Dynamic, and then lastly about Serena-6 in this study design. Primarily, we are going to discuss about the outcome based on the ctDNA in this study. CheckMate 816, why they want to assess ctDNA? Primarily based on two things. Whenever they did a multivariate analysis in the earlier studies, ctDNA clearance has shown very good outcome in terms of both PFS as well as OS. And this ctDNA based assessment better in terms of radiological outcome, and it has shown similar outcome as compared to the pathological assessment of outcome in this situation. And this is the study schema, how CheckMate 816, they have started from the study towards the last publication happened in 2025 where they shown overall survival advantage. But they have not published a separate paper or details with regarding to the ctDNA assessment in this situation. So I digged out to the subgroup analysis. Total 358 patient has been enrolled, but only 89 patients we have biomarker based evaluation data is available. That is only 25% of population in this study design. And 43 in the control arm and 43 in the experimental arm in this situation. How they analyze ctDNA pattern in these patients? They mainly did tumor guided ctDNA panel, whole exome sequencing in this situation. And what they try to analyze is, they try to analyze the baseline level of biomarker evaluation and then check for clearance at cycle 3 in this situation. What is the outcome with regarding to ctDNA? Two things they found out. ctDNA clearance rate is much higher in the immuno plus chemotherapy combination in comparison with chemotherapy alone. Second important thing is, those all patients who cleared ctDNA, irrespective of whether it is in the immunotherapy arm or chemo arm, they have shown better outcome in terms of both PFS as well as overall survival in this situation. Another interesting point I would like to share over here is the ctDNA correlation with path-CR rate. So we see good number of patients able to clear ctDNA, but not all the patients who are having ctDNA clearance showing pathological complete response. So there is a mismatch is there. Even though patient is showing ctDNA clearance, they are not having pathological CR in this situation. So coming to this, there is only small cohort of population has been evaluated for ctDNA in CheckMate 816 study, and it has shown prognostic value in terms of both PFS as well as OS advantage in this situation. But we do have several prognostic markers in lung cancer. Like for example, in CheckMate 816, PD-L1 serves a very good prognostic role, TMB. But how much added value the ctDNA going to add, we have to see in the subsequent analysis or subsequent studies. Moving on to Niagara study. Yesterday, Dr. Sendil Rajappa sir discussed beautifully regarding the ctDNA part of Niagara study design also. Now we see exclusively what they are analyzed in the ctDNA part. Compared to CheckMate 816, in Niagara, they included larger number of biomarker-based evaluation population in this study design, and they mainly based biomarker evaluation is based on Signatera-based tumor agnostic or tumor-guided test in this situation. And we have 450 patients in the biomarker evaluable population. They done ctDNA analysis at three parts. One at the baseline, second after completion of neoadjuvant treatment, third at the time of cycle 1 of adjuvant treatment starting. So this is the graph. I will go one by one. Irrespective of type of treatment, at the time of adjuvant cystectomy, when they do at the time of adjuvant assessment, the ctDNA positive rate is only 10%. Second important thing is ctDNA clearance. Again, in this study also, the ctDNA clearance is higher with combination with immunotherapy along with chemotherapy. Third important aspect is with regarding to the event-free survival benefit. Whenever the patient having ctDNA clearance, these patients tend to do much better compared to those who are having ctDNA positive. Another important finding is those patients who had ctDNA clearance with chemo as well as immunotherapy, they have better survival compared to those who are having ctDNA clearance with chemotherapy alone. This is also one finding, but I don't know how much is the statistical significance for it. Another interesting thing here they pointed out here is not all the ctDNA clearance means the pathological CR is there. And another important factor is ctDNA positive means nearly they will not achieve path CR in this situation. And coming to the conclusion part, EFS is correlating with irrespective of whether the ctDNA is negative at any point in time. If baseline is negative, they have very good survival. If they're able to clear the ctDNA, then also they'll have very good survival compared to those who are not able to clear ctDNA in this situation. Coming to the next important study, compared to those two studies, CheckMate 816 and Niagara, Dynamic has shown that we can able to modify the treatment or guide the treatment based on ctDNA assessment. What they have enrolled in the patient, stage 3 colorectal patient who are eligible for 5FU-based treatment regimen have been randomized between two arms. One is standard arm and another one is experimental arm, which is tumor-informed ctDNA analysis, which is safe sequencing technique they analyzed. In this study, what they try to do is they try to escalate or de-escalate treatment based on the reporting of ctDNA, and they try to compare with the control arm also. De-escalation means they can de-escalate from 6 months of treatment to 3 months of treatment, de-escalating from 6 months of oxaliplatin to 3 months of oxaliplatin, or for observation. And the primary endpoint here is ctDNA negative population, 3-year RFS, and for ctDNA positive population, it is 2-year RFS. Coming to the outcome in terms of ctDNA negative population, with regarding to 3-year RFS, it is approximately 87%, which is confirms that low risk cohort, the survival advantage is reasonable. When they try to de-escalation, the adherence rate is close to 90%, and the usage of oxaliplatin is significantly reduced from 90 to 35% in this situation. It is failed to show non-inferiority margin by a margin of 0.3% because they kept a cutoff of 2.5. The non-inferiority margin absolute here is 2.8. When we try to subdivide the subgroup analysis, in T1 to T3 N1 cohort, they are able to achieve the non-inferiority margin, but it is not pre-planned for this in this situation. When they try to escalate for patients who are having ctDNA positivity with escalating to FOLFOX-IRI regimen, they found escalation is not showing any benefit in this situation when we try to escalate for ctDNA positive population. So coming to the conclusion, ctDNA negative cohort, there is some data is there, even though it is not statistically significant. Clinical outcome wise, it is good. It has shown that oxaliplatin we can reduce in this population. Also, adverse event and the rate of hospitalization is significantly lesser. For ctDNA positive, it is phase 2, it is negative. Phase 3, we need to await for the result. Coming to the another important study, Serena-6, the dynamics is entirely different here because they are trying to assess ctDNA in metastatic setting. What they're trying to assess is those patients who are having ctDNA, patients who are started with CDK4/6 inhibitor along with hormonal therapy. They try to serially monitor for evaluation of ESR1 mutation in the population. Those patients who are having ESR1 mutation, these patients will be randomized between changing the line of therapy to ESR1 guided, that is camizestrant, versus continuing with same line of treatment. So as mentioned earlier, they have very high number of population initially to be screened. Close to 3,000 patient has been screened to enroll close to 300 patient into the study design. What is the hypothesis and rationale behind the study design? The nature is whenever the mutation numbers are less, we are able to attack that thing before any biological progression. So we have very less mutation, the response rate will be much better. That is the idea behind it, and also to establish the utility of ctDNA in this situation. As we all know that camizestrant has shown benefit in ESR1 mutant population based on Serena-2 study, and the rationale of changing the line of treatment to another drug based on the biological inhibitor well established in PADA-1 study also. Coming to the primary endpoint, that is progression-free survival. The progression-free survival, median progression-free survival is 16 months when they change the line of treatment to camizestrant on the arrival of ESR1 mutation, and the secondary endpoint includes PFS2 is also significant. At 1 year, it is 85 versus 74 in the population. OS data is immature at this point in time. What are the key findings with regarding the usage of Serena-6 in this situation? In ctDNA testing, which is done serially, it is highly sensitive, and also they try to include all ESR1 mutation into the population. When it comes to the study drug camizestrant, it has shown activity in ESR1 mutation in Serena-6, and also the usage of camizestrant is associated with reduction in ctDNA, and it has a very good safety profile in this situation. And they are also trying to analyze, apart from PFS, they are trying to go for PFS2 and also OS data in this situation. Coming to the disadvantage or limitation with this study design is they have not allowed crossover in the control arm for usage of camizestrant in the situation. Another important limitation is feasibility. As I mentioned earlier, they were screened close to 3,000 patients, and they are doing serial ctDNA monitoring every 2 to 3 months for this population. So again, cost and other factors will be an issue when we try to incorporate in this regimen. Another key difference over this study is usage of chemotherapy after progression much higher in the experimental arm compared to the control arm. Close to 10% difference is there. Probably that might also add to the advantage we need to see over this situation. Just a cross-trial comparison. I know it is different group specific. It is different in the setting also, in which they use neoadjuvant, something in perioperative, something in adjuvant, and something in metastatic setting. By and large, in first 2 trials, CheckMate 816 and Niagara, they try to treat ctDNA as a prognostic marker. In prognostic, it is showing benefit in this situation, but there is no role of prediction based on these 2 trials. When it comes to the other arrangement, dynamic study tried to see whether we can escalate or de-escalate treatment. When it comes to de-escalation, it has very good data for 90% adherence rate is there. We are able to omit oxaliplatin in significant number of population. Coming to the Serena-6, Serena-6 is trying to look into minor and minor subgroup of population. What they found out in this is they are having both PFS1 as well as PFS2 advantage. Limitation over for this studies, there is no crossover or feasibility in this situation. With this, I would like to thanks for giving me this opportunity. Thank you.
Can I invite Dr. Nikhil Ghadyalpatil? And Nikhil's panelists are Dr. Pushpendra Hirapara, Dr. Sushant Mittal, he is there? No, he's not there. Dr. Karan Sood, Dr. Chirag Desai, Dr. Amit Verma. Dr. Amit is also molecular oncologist along with medical oncologist. Dr. Shiris Alurkar sir, Dr. Satyankar Gupta, and Dr. Anant Ramaswamy. अनंत तुम्हारा नाम नहीं बोलते बैठने की कोशिश कर रहे थे.
Thank you, Amish, for this opportunity and this difficult procedure which we want me to discuss. The reason being, when he said cross-trial comparison and cross also DNA program on basis on the ctDNA, cross-site comparison. Normally, we are already, it's a sin for us to really do cross-trial, and here you are talking about cross-disease also. And that is, I believe, I would say, the most cardinal sin oncologist is going to do here. But let us see what we have in store for our discussion. So till now, we know about ctDNA, and we have been using in the last few years about its usage, especially in the real-time treatment monitoring. We do take treatment decisions depending upon the genomics and, of course, depending upon the relapse. But I'm going to ask my panelists about this one. Let me start with Amit here. Amit, is MRD the real thing now? We always used to be taught all throughout about only liquid cancers, but I think more and more we start hearing about MRD also in the solid tumors. Is this the way forward?
I think MRD is now a real thing for solid tumors as well. With the advancement of technology, where we are able to pick up a very small level of ctDNA, that is, the sensitivity is getting higher and higher with the newer technology. We are really able to identify any circulating DNA, which is a reflection of residual disease. And I think as new technology is also coming up, like CAP sequencing, which is considered to be ultra deep sequencing, where the sensitivity will go down far, you can say, better. And then the true molecular response will be evaluated and MRD will be considered actually.
So you think this is something which is going to stay. Now the question what we want to answer over here is this. How to really compare these trials which have per se there is no commonality except for the ctDNA. And if you look at the indications where these trials have been done, we have a trial in the peri-op, or I would say neoadjuvant. We have peri-op like Niagara, we have got adjuvant, and we have got metastatic. So why should we at all do all these trials? Anant, what made probably, Dr. Amish is not here, I wanted to ask this question to him, but what probably would have gone through his mind to understand why we really need to really get this comparison like this?
So I think the first thing is, as he said, MRD is here to stay, right? And we are all trying to understand where best to place it, and more importantly, what to do with it. And across scenarios, we all agree, and I'm sure you'll come to it, it's that it's showing prognostic value everywhere. But what do we do with it? And since we don't have that data, we are looking at combined sites like this. Maybe that will give us a greater sense of what to do with it. I think that is my reading of why this topic was given. In that, let's all pull together the data and see where it leads. Because it's all exploratory in terms of what to do.
So when this topic was asked, these were the thoughts which came to my mind. So we are looking at different paradigms. We are looking at the paradigms. Of course, I'm going to cover more on dynamic rather than dynamic 3, but more about de-escalation, resistance interception, what Serena has told us, prognostication, there are so many, I would say, assays which I'm sure Amit would further discuss in much more details. What are the challenges in implementation in current day-to-day practice, what we are looking at? What works and what doesn't work? Like in dynamic, probably it has worked, but not for dynamic 3, and what are the reasons for that? And are we going to have any kind of practice changing thoughts over here at the end of uh, today's discussion? And also we would like to understand what ctDNA does in terms of PCR, ctDNA clearance, what about emergence, and what are the other correlations in this regard? So before, I can start from this side. Sorry, I don't know everybody's names. I'm so sorry about it. But what questions this trial really wanted to ask, and I really want to go through all the trials over here.
I think the first trial, CM 816, basically was to see about the EFS and OS in the long
In terms of, we'll stick to ctDNA only over here.
Yeah, ctDNA, they wanted to see ctDNA clearance, its correlation with PathCR and long-term overall survival. And coming to Niagara, yes, they did the same, EFS as well as the relation with the PathCR and long-term this 2-year OS also. Serena-6 was a dynamic study, just serially monitoring every 6 weeks for ESR1, only one mutation. The emergence of that, and would switch the patient to some other, switch to camizestrant plus CDK4/6 inhibitor, and they also wanted to see the change in the this progression-free survival, improvement in the progression-free survival. Regarding dynamic 2 and 3, 2 they wanted to see only in the stage 2 colon cancer patients, but it was a negative study. They wanted to see whether, if there is a ctDNA negative patient, or a ctDNA positive patient, what is the long-term outcome, 5-year, DFS. And in the stage 3, the main I think stage 3 was quite significant, because we are all interested to know whether de-escalation or escalation, depending upon the ctDNA positivity, does help, but that also eventually was a negative trial.
So when I really looked into all these studies, what I realized, they basically played these two important roles. One is treatment decision maker, that we called it more of a predictive biomarker. And second is, of course, the prognostic, which was more of a exploratory in most of the trials. As you can see over here, in the dynamic 3 as well as Serena-6, it was more to do with the treatment decisions. And when you look at 816, it was more of an exploratory. And Niagara, of course, it was a pre-planned, but again, it was more of a prognostic information. Dr. Chirag, sorry, before that, may ask you this question. Already it had been shown tumor-informed and tumor-agnostic assays. Now, one is what it is, how we really need to interpret, especially for the sake of students over here, and how easy or difficult are the assays to implement in Indian context today?
So basically, out of these 4 trials, 3 have done this tumor-informed. What they did is, on the tissue, they first did the NGS and get these list of the alterations,
Signatures,
which we can then later on detect or track. The last one was tumor agnostic. Regarding the Indian context, many of them are not available. I think I am aware about Garden 360, which is we are using in sometimes. So implications in Indian context might not be the magnitude which already have done in the clinical trial settings.
So, Dr. Chirag, we have Garden, let's say, we are talking about Serena right now, but are we okay to kind of switch, or because ESR1 can be detected by multiple, I would say, multiple platforms, I would say. And are we kind of ready for usage, assuming that the drug is available with us?
So I will give a little context to this trial. We tried doing it in NSCLC, EGFR mutated, when first and second generation TKI were being used to serially look for emergence of T790M mutation and randomize the patient at that point in time. But that actually didn't work. For breast cancer, it was tried in PADA-1 trial, earlier. And there we could find the improvement in the PFS. And the same thing was seen in Serena-6 trial, that we were able to improve on the PFS. But crossover was not allowed. So that was the drawback of this trial.
Yeah,
So,
we'll discuss Serena-6 in details later.
Right.
But about the question,
so it works. In Serena-6 trial, this concept works.
okay. So these are basic, I would say cardinal, I would say differences. We'll not go into much details. I am sure it has been already been discussed. And this is a more of a cross-design trial comparison, as you can say. Just to focus on some of the important differences, dynamic was a stage 2. And as I can mention over here, the dynamic was a prospective decision maker. Niagara was an exploratory biomarker, and of course, as we know, ESR1 mutation guidant treatment was offered in the Serena-6. And these were the baseline ctDNA discussions. I think this has already been discussed in details. So let us quickly check on to certain trials on what has these trials have offered to us, and CheckMate 816 has already been discussed. So again, coming to Karan, can ctDNA replace or augment the PCR information?
So, sir, in this trial, basically, we were giving the neoadjuvant immunotherapy, and PCR was a surrogate, but this trial wasn't powered to see that the ctDNA.
PCR was a primary.
Yes, but ctDNA wasn't the primary analysis; it was a subset analysis. But definitely, we saw that patients who had a clearance of ctDNA had a better PCR. But again, patients who had PCR, were they not relapsing further? That is again a question. So I think it can augment PCR at this point of time. It will not replace for the current time. We'll need to see more, because I think the kind of tests, the limit of detection, the type of assays that we are using, we are still marred by the sensitivity and the specificity.
Dr. Girish, the PCR was around 24 versus 2% in the Nevo versus otherwise. And if you look at the ctDNA clearance, was 50 versus around 30%. So there is not, I mean, there is some kind of a correlation, but that is not an absolute correlation over here. So are we really looking at a level of what we call as multi-omics, where we want to look for pathology, you want to see radiology, and you also want to see genomics, and then we want to take a decision in such patients?
Yeah, so just putting our bet on one biomarker, which is the ctDNA, is not a good strategy, I think. Although, as Dr. Anand said, it is there to come, but still in clinical practice, in a day-to-day practice, I mean, you can see a show of hands how many actually do a ctDNA and decide the treatment. So there is a dichotomy between the ctDNA positivities or negative and the PCR rates. So real time, I don't know, in real practice, difficult to practice.
So Anand, since you said you also see lung, so I just wanted to ask this question, that if the patient is, let's say, not in PCR, or let's say ctDNA is also positive, now you are really concerned, are you going to escalate the treatment?
No. As I said earlier, we don't know what to do with it. We just know that that patient is not going to do well. But do I have data in any tumor, and I could be corrected, to escalate based on positivity? I think that does not exist. So then I won't.
So correct. So we don't have predictive information for now, but at the same time, we probably would get enough prognostic information that this patient is not going to do well. In such scenario, again, Dr. Chirag, does it make more sense to bank on more of perioperative strategies than only neoadjuvant, because there is nothing to fall back upon?
So again, I will give example of some other trial. In Catherine, in breast cancer, we depended on the PCR, and that worked, changing the treatment based on whether patient has PCR or not. And in Dynamic 3, that approach did not work. So we need to have more than one factor. We should not rely only on either PCR or only on ctDNA or clinical stage, but we should have a combination of all these factors. We should come out with some mathematical model that will help us in guiding the treatment.
Okay, so Niagara was presented very well by Anbarasan, and some important points, as you can see over here. One was, there was a drop in the ctDNA. Again, let's say 1,000 they started, 400 they analyzed, and the number of patients with on IO plus chemo had a much more drop than otherwise. But there were certain subset of patients, around 9%, who were continued to remain positive post-radical cystectomy also, and that had poor prognosis. So again, the story is getting repeated again and again that if there is a persistence of ctDNA, that these patients are not going to do so well. If the patient gets a ctDNA clearance, irrespective of the arm, the outcomes have been better. Clinical implications, if I can start from this side, what are the clinical implications of Niagara for now? Are we just happy with this information, prognostic information, or whether we really want to have something like IMvigor 11, although not in this setting, but that is a way forward.
Yeah, so the clinical implication could be, as Dr. Senthil pointed out yesterday, suppose we give new adjuvant chemo IO for a patient and who later on declines, achieves a PAT CR, we can do his ctDNA also, and if that turns out to be negative, then patient can be, shifted to CTRT.
But not for the forward matter. No. Once you embark on Niagara, you probably you are going to stick to Niagara, right?
Yeah.
Is that right?
Yeah.
Again, Amit, this Signatera, right? This is something we have been discussing since yesterday. I'm sure this has been discussed multiple times. I think it is just getting available even in India for now. But how difficult or how easy to really get this thing if you really want somebody has to replicate the same thing in our practice? Do you foresee that thing happening? Because again, tumor-informed testings is the way forward for all these trials.
Yeah, so all these tests are quite sensitive tests. First of all, we already know, and tumor-informed. The only requirement is that you should have the tissue with you, and that too properly fixed, otherwise all the things will go haywire. That is one. Second important aspect is because this is a liquid biopsy which has to travel all the way to the US for analysis, it takes more than 7 days for any logistic reasons actually. And the quality goes down dramatically, what we have seen, and the TAT turnaround time always fails actually. If you were to make any prognostic decision based on this, which will be delayed for almost like 3 weeks. In the clinical trial setting, it is all controlled, everything is all fine. And the third important aspect, what I personally feel, that the context of the Indian context, we do not know the genomic signatures which are going to dominate, and we do not know if they have truly validated those, you can say, nuanced alterations to follow up easily. So there would be some differences as compared to what we see in India versus the West. These are my potential challenges that I can foresee actually.
So we probably would want to have something more like an Indian Natera or something.
It is easily doable, not at all complicated. The principle is very simple.
Just that needs a validation.
It is just, yes, that's all.
No, I don't think anybody is doing it, right?
So nobody is doing it. If you prescribe the tissue and the liquid biopsy same time, you are developing your own validated data actually. So it is, you have to how to interpret it.
So actually that's what I wanted to ask, that most of this thing is not readily available in India. You have ctDNA platforms available. A lot of Indian companies are doing it. So shall we be using that? Say for example, let's say about breast cancer, you had Oncotype DX, you have good, very prognostic and predictive information. We have developed our own CanAssist. But the question is that for ctDNA, can I use the labs that are doing in our country and how reliable they are?
So this is what I was wanting to ask. So show of hands for those who've used Indian ctDNA based testing. Okay, so that's at least 50%. So if we are not, so obviously some of us are convinced that this works. So, No, so I'll come to that. So a couple of these I won't name, they have actually published data on ctDNA dynamics. 99% of at least my patients can't afford Signature, right? So what we can do is
99.99.
Okay, great. So you can't say that. You can't say that. No. Hang on, give me a minute. So the point I'm trying to make is, in patients where we cannot use this, right? If we have some published data, and there are a couple of this ones, I think it makes sense to use it if we cannot use this, because they are published, validated platforms. right? I don't think the tumor informed is being done by any of these. They're all doing tumor agnostic.
Correct.
But as Dr. Amit said, the tech is easily reproducible even here. And the last point I want to make is that it does not matter for signature whether you're an Indian or a non-Indian patient, because it is patient specific. Those 16 genes are for that patient. So it will capture those markers. So it does not matter. I mean, I hope that kind of makes a point.
Quickly, my observation has been when, we have so much of stalwarts here, sometimes there is a radiological progression in, let's take breast or lung. But ctDNA is negative in the Indian lab. And you have one lymph node here and there coming, one bony lesion here and there coming, but ctDNA says 0, VAF, nothing seen. How do we interpret that? Do we take that
the
as...
tumor doesn't shed, I mean, simple.
So tumor is not shedding, that's the only thing, but how do I know the validity of the lab which we are doing?
We don't know, but in a broader concept, I mean, just give me a second, a quick comment to that extent. Chinese believed in their IO, Chinese believed in their CAR-T. Now gradually, world is believing. So we have to start believing in our technology. We have to start believing in our laboratory. Then only people will believe, the other people will believe.
So
Quickly,
quick point.
Because I got only 10 minutes.
Their earlier data of ctDNA, when they said the sensitivity was 80%, and we labeled as that 20% are non-shedders. Now we have data coming from India of the US labs that sensitivity is going to 97%, and in this ASCO GI, 100% actually. So it's the test which is not picking up and not a biology calling it that they are non-shedders. So if your ctDNA is not picking up, please do not label it as they are non-shedders, your test is not picking up. I think so that's the lesson.
So you are talking about the false negativity.
Yes.
Yeah.
So an ideal test should pick up.
And again, when the tumor volumes are less, you are likely to have, there will be lesser shedders in that.
We have moved towards screening in non-malignant people.
Correct.
So if you have a tumor, your test ought to pick up. Now I agree, the current versions do not pick up, but if you see the posters that are lining up and the data that we are touching 99%. That if you just, instead of 15 gene, so Jeannie showed in this year's Nature's paper, that if she were to do 50 gene probe in the same signature, she missed, the false negatives, she could pick up and the sensitivity improved. So it's not that they were non-shedders, it's the current tech didn't pick up.
So, no, so I'll give you, yeah.
I'll talk about colon.
No,
the
correct.
earlier
So
ctDNA
I will give,
15%.
since there are a lot of questions, we have increased 5 minutes of your time
thank
to
you so much.
allow the questions.
Thank you.
Yeah, absolutely. So I'll tell you, I have 5 patients who could afford both. Because I told them that first time we will send to Guardant and Indian lab, both together, and we'll see. 5 is a very small number, but those who can afford both together, except for VUS, I found they were congruent with each other. So, Viraj, your point is very well taken. That is what I also said. But I agree with Chirag Bhai also that sometimes, somewhere we'll have to move forward. There was a time when HER2, even today HER2 IHC is still not, very standardized. But we still go with our Indian labs. We don't send HER2 to US labs. So somewhere we'll have to start and collecting our data, I feel that. And that's only where we will move forward.
So the other thing is that we are also we needing to standardize how we collect. A lot of times not using the Streck tube, not able to send the sample within a specified period of time. The samples are lying in the hospital, so that's automatically getting degenerated. And we've seen that in the CGPs that we are doing in Tata also. Sometimes there is the CGP is negative. As sir said, that there is something in the radiological space, but the ctDNA is not there. The CGP is negative. So I think that logistic problem that we are facing is also one component apart from the specificity of the test.
Sorry, but we just published last year Indian experience of Guardant, and the median TAT is 10 days. So we published this.
Now it has increased to more than 21 days actually.
No. The MRD version, the Guardant Reveal, not the 360. The garden reveal, and we have published this. It's 10
Okay,
days.
we'll just quickly move on.
So I have just an
comment?
important
Yeah,
comment actually.
yeah.
While we are talking about sensitivity, we have to also take into account the type of alteration we are looking into. Had it been like amplification or fusion, the expected sensitivity should be ranging in the 50 to 60%. You will miss all the time, practically speaking. Even the US lab will also miss it. If it is a point mutation for that matter, the sensitivity will go to more than 90%. So just be in a tumor-informed context, we can just have some that prediction handy.
Okay. So we'll quickly move on to the next trial, which was Serena-6. It has its own, I would say, criticisms over here also in terms of, PFS2 and lead times and all that. But it's quite important to really understand that the numbers what we are looking at were substantially higher in terms of the PFS, PFS2, better quality of life, and so on and so forth. Again, question is how, again, feasible it is. Maybe I can start from this side. How feasible it is to really have something like a Serena-6 now that, assuming that we have got all camis and everything available with us,
No, it's
every 2 months, 3 months testing by Guardant,
not feasible, not feasible.
not feasible.
Even otherwise also we achieve a PFS of around 15 months with AI and CDK4s in the first line. So I don't
There was no crossover which was allowed in this trial. So could we probably would have done better, or if you think that had we used the same treatment in the future, if not immediately, would that make a difference to these patients? What is your
Yes, it might have. Yes, it might have make the difference if this, because this is active drug, and if that have been given in the later line, yeah, the OS might not.
So if you look at these numbers over here, ESR1 mutated, it almost dropped to almost 100% of patients responded when they were on CAMI, and as compared to the other AI arm, they continue to increase. So that is all about Serena-6. Now, no, there was no crossover.
crossover was not.
No crossover.
One more thing with Serena-6, my biggest issue, and that's what yesterday the first slide is, that instead of de-escalating, we are escalating a lot. Assuming, see, this is 16.6 versus 9.2 months, right? Assuming that all of them would have waited till
Exactly
you're coming?
what we discussed just now.
No, if all of them would have received camizestrant.
Correct. So we don't have the answer for that.
What I'm saying is that, I'm asking in general, that if all of them would have received camizestrant, once they had a radiological progression, instead of ctDNA progression, the thing would have been different. Are we jumping the bandwagon? That is what I'm worried about.
Correct. And that's exactly what we had discussed, that are we really treating the disease, or we are just treating the lead time bias, where we are just picking up the DNA at early stage, acting on it, but technically we are really not changing anything. The more important outcomes of this study is more about the quality of life and time to subsequent therapy, which to my mind are more important endpoints than only the PFS. Again, the PFS2 criticism is whether it's a 3 lines versus 2 lines, and we can discuss more about it. But as been pointed out by all my panelists, that in Indian scenario, it's quite a challenge. Funnel approach over here, as we discussed, it took them 3,000 patients, Dr. Chirag, to get to 300 numbers. So look at the number of patients, what they wanted to screen. Again, is it something what you want to make a comment on?
So, let us look at this trial as a concept. That concept works. Now, whether it is cost effective, how to do it in our patient, there are always some patients who are affording. If I think of my patient in my private practice, that could be around 5 to 10% of the patient, not more than that, but that's possible. And if the cost comes down, let us say if it is free of charge, I think all 100 will follow this approach. So the concept is working.
But then in that case, sir, there will be the different aspects also, like anxiety, once you detect the ctDNA, and if we were discussing.
But if you are getting a survival benefit, then I think that anxiety can be really tackled over here. And yeah.
So Amit, can you use ddPCR to detect ESR1 in the blood?
Yeah, I was coming to that actually. In Indian context, it is much easier to do ddPCR at a nominal cost of 7,000 to 8,000 rupees for multiple and sensitive is equally good like NGS. So nothing to lose actually. So we are talking about detecting the ESI mutation. It is not the level of ESI mutation. Once it is detected, you start your chemistry or whatever cert you want to start. But the whole idea is it is detectable. You can start screening your, and the predicted time for post AI, it is beyond 6 to 8 months. To start thereafter, not just immediately after 2 months time. That will be a
Another
smart
thing
move.
that, a lot of dichotomy in the biology. At one site in prostate, we talk about radiological PFS, right? We wait for the, PD to happen in the viscera or the bone. And here we are waiting that it should not happen. So the biology of the disease also needs to be taken into account. The marker as such, which we are looking at, the ESR1, or as someone said, EGFR, that also needs to be, seen in per se, the disease, what we are looking at. So I think the answer could not be a black and white. It's more of a gray zone, and I think we are eventually developing.
So, but the more you look at for next couple of years or maybe few years down the line, the more trials like this are expected to happen to all of us. We have to live with it, and we have to really make amends with it, and we need to understand, and eventually probably it may so happen that we probably end up accepting most of the trials. Now I have some questions for Anand over here. Anand, more about dynamic. As you know, the 5-year data was recently presented, and again it showed that the patients with the de-escalation strategy also, it really, so in the ctDNA based strategy, it worked for the patients. And this is in terms of almost in all the set of patients, as you can see over here. Yes, the patient with the T4 did not do as well as compared to T3, but these are more of a, I would say, more of a dissecting the data over here. And this is about the 5-year data, again, as you can see over here, that the 5-year OS has been almost been similar, 5-year PFS or RFS has also been similar. Now, are you concerned about this 6% of false negative patients?
So I think this was one of the trendsetters, and this is now 3 years old or 3.5 years old when it was initially published.
And
so
the
that,
second is published just now, last year.
No, the initial
was
data.
2022. Yeah.
So I think this was a point made by Viraj and all the others also, is that this sensitivity will improve to close to as high as it can get as the tests improve. And even this, the RFS and OS, the curves are right on top of each other, right? It's 93% and 88%. You probably cannot get better than this.
So we are happy with the outcomes of this trial?
I am at least.
So we are happy with the de-escalation, we are happy with no
in
toxicity
stage 2 based
in
on
stage
this,
2 patients. Of course, we also will discuss in brief, although I didn't have too many slides over here for stage 3. Check with Amish whether you want to we discuss dynamic 3 also. But since we have mentioned already about false negative, it again depends upon the LOD, level of detection. Even during the trial, they have actually improved in terms of their LOD over a period of time, and that is how even the trial should be designed. That as you go through, everybody needs to adapt to these processes, and that has really helped the outcomes of those patients. Dynamic 3 failed, Anant.
So again, we were discussing this yesterday, is that if you're a statistical Nazi, if you're like stats is everything, then of course it failed. There is no doubt on that, right? But the delta was 2.5%. If you're, more into that, the upper limit of the delta was 8%, 8%, I think. So that is a
7.5.
no, it crossed 7.5, which is why it was negative. So yes, the trial failed, right? But it does tell you that almost 65 to 70% of your patients actually can do with lesser therapy even in stage 3. That is definitely a learning from this study. And as the tech gets better, that I think everyone here agrees, that delta will come down. The second thing is, this is again the first of its kind in stage 3. So give the tech time for further studies, it will come out to be true. That's what I think, and we can take,
And it has also something to do with this 13.5 false negative rates over here, because the 6 would not hurt the low risk disease, but 13 for a high risk.
So that I completely agree with you. In fact, the T4 N2s, there was definitely a problem. That I agree. The other thing is, assuming you have a ctDNA positive, is the way to escalate chemotherapy. It probably should be, it at least can be biomarker based. Let's say that if it was PDL1 positive, Escalation on that might have made a difference. So these are concepts that will come later. But at least this is a start which says that this is feasible, and you can, interpret the 2.5 as you want. I think Chirag sir wanted to make a point.
So, I mean, for de-escalation, I was trying to tell you that T3N1, anyway, we have the data of giving 4 cycles of capox and not going beyond that. So, anyway, looking at the stage only, we are de-escalating. So, is the biomarker-driven decision necessary?
So even so in that, for example, in stage 3, if you take overall, it is 70% probably do not need adjuvant. That is at least if you believe in the concept of ctDNA. It will be 75-80 in low risk, stage 3, it will be 55-65 in high risk stage 3. So you have an additional data point to make a decision. That is what this tells you. I mean, that is my reading.
We have to have the combination of all these
factors.
Yes,
of course. Yes, agree. Additional data point.
Okay, so I think few of the slides I think we have already discussed. I may just skip these slides. And, these are quite important points in terms of discussion, but I think about the PCR and ctDNAs for Niagara as well as everything has been discussed. Since we are running short of the time, I just want to come to the last part of it. Implementation and reality of every trial and what are the challenges over here. Now I just got this, put this information into the AI, and these are the graphs what I got over here. Every trial has some amount of limitations. As I mentioned, to screen, to get those 300 odd patients, we had to screen 3,000 patients. Again, in Niagara, not all patients were positive at the baseline. Only 40-45% were positive. As we discussed with the 816, these are low volume diseases. They may not be shaders all the time. Same time, many of these patients, if you look at the numbers, again, it was an exploratory analysis, very small numbers, and dynamic we have already discussed in terms of its limitations of false negative. So every trial also has their own challenges and limitations. And as I try and understand what is the clinical validity as well as clinical utility, dynamic has a strong clinical validity. Clinical utility, although one can question phase 2, but I think it is much more acceptable to all of us. Serena-6 again is a strong validity. Proven, but again, it has its own challenges. Niagara again has strong clinical validity over here. Utility again unproven. What are we going to do with this prognostic information? Are we really, there is nothing more to escalate in this particular setting. CheckMate again is a small information for us, but it is quite a proof of concept principle. So coming to some of the important thoughts which I thought I should share over here. When ctDNA should not drive treatment, one is false negative rates exceed the clinical threshold. When there are no actionable therapy exists, even if you do sometimes ctDNA, so now we got Serena-6 because we have something to fall back upon. But what if you don't have, and if you have a trial and if you have a biomarker, and if you continue to chase, but there is nothing to really, I would say, to be given to the patient, there lies the challenges. Tumor biology limits ctDNA shading. Remember that one, as I mentioned. There are certain areas like peritoneal, CNS, pulmonary, micromets. They may not be shaders all the time. Viraj may differ over here, but since this is what it is, for now, for my limited knowledge, whatever I could gain out of all these preparations. Assay not validated for specific indication, and clinical risk factors already manage the treatment. So we really need to integrate clinical. We are also looking for now pathological, we are also looking for radiological, and now we are looking at genomics. So I think we have completely entered the era of multiomics, and that is where I would see more and more, I would say, trials getting designed and being treated, utilized. When ctDNA can inform treatment decisions, it's quite important. When it is validated, like nicely happened with dynamic, as you can see over here, IMVigor 11, as we know that ctDNA is positive, it makes an impact for the patients. Tumor-informed assay is something what we will be really looking forward to even in India. Actionable treatment decisions exist for both ctDNA and ctDNA negative results. So, as I mentioned, escalate, de-escalate, and these are the ways of looking at it. Again, it's a serial test. It's cannot be a binary all the time. If you look at most of the studies, one test, like dynamic, only 2 tests, 4 weeks, 7 weeks, and then there was nothing. But I think the more we look at serial rather than more of a continuum, rather than looking only at yes or no, I think that is where I would say that the real potential of the ctDNAs can be unleashed, and that is where patients can have better, I would say, outcomes. These are the questions we already have discussed. Monday morning, any specific study, maybe Anant or anyone who can take that, this is the study at this what I would really want to embark upon by Monday, or we already started doing it? Dynamic. I think that's where I think I would say most of us probably would agree to. Yet at the same time, the number of trials which are happening in this setting are far too many, and exactly on a similar lines, dynamic rectal, and you can talk about Serena-6 and all that. So a lot is happening in the same setting, which is in the ctDNA space in terms of therapeutic outcomes. So certain unresolved questions exist for us. Does early detection translate to longer survival or just early diagnosis? As I mentioned about Serena-6. Treat all versus only treat ctDNA positive, like IMvigor 11. Which paradigm wins? We do not know. There is no head-to-head over here. But I would say both probably would coexist as far as the patient outcomes are concerned. How do we handle ctDNA dynamics, rising, falling, fluctuating in real time? Whether the ctDNAs are rising, are we doing something, or it is just that it's just adding to patient anxiety, and so on and so forth. So I think that was probably my last slide. This is my key takeaways. ctDNA is not one thing. It's a platform for technology with different roles. As a sensitivity, we need to really understand what we are going to do with the test and the patient for that matter. Serial testing is the future, and the strongest evidence, again, as I mentioned, has come from dynamic as well as IMvigor 11. And we must resist premature adoption. There are certain studies which have told us that it's not always the case for our patients. So with this, I stop here and hand it over back to Amish, unless he has any questions.
Thank you so much. I think you have done a wonderful job, Nikhil. But you would not have done such wonderful job without wonderful panelists.
Absolutely.
So the last session was a very interesting one. I think Dr. Anbarasan as well as Dr. Nikhil and the whole panel really brought out all the finer points that were required with regards to ctDNA discussion. And honestly, in the last 2 days, I think most of this conference has been more about ctDNA rather than anything else, although I'm not very sure whether we are really wiser at the end of all this. So just to go through, we first had the Serena-6 study. Metastatic MBC patients who had an ESR1 mutation that were detected. Out of 3,300 had this. These were then randomized to receive camizestrant as opposed to continuing the same line of therapy. What is important here is that the ctDNA was done by the Guardant 360, and that was done every 2 months till the end of therapy, and then one more after that. So given a median of 16 months, we are talking about 8, 10, 15, and 20 tests that is done over a period of time. The logistics of that is very important. And what this showed, yes, it was a positive study with a good improvement in the PFS. And this study basically concluded that the primary endpoint, that was PFS, was met. Several secondary endpoints were met, the PFS2, as well as the chemotherapy-free interval. It also showed a significant reduction in the ESR1 mutant allele frequency in patients who received the new drug. And it has basically demonstrated that ctDNA monitoring to detect and treat emerging resistance is possible. We've already discussed many of the lacuna in this study, most the crossover, which was not there. And therefore, while this is a very interesting concept and is most likely going to go forward, until we have some OS data, we are not really going to be accepting this. At least that's what is for me. Is anybody here ready for this on Monday morning, assuming the drug is here? No, it is in the situation that it is. Absolutely no. What about with that data? No, what about that data which says that the earlier you use something for ESR1 mutant, it's always better. Response rates are higher and PFS is better. Yes. No, not yet. No. The study was the second was the CheckMate 816, and what I'm going to highlight here is just that the points when the testing was done. So here, the ctDNA testing was done at baseline, that is prior to cycle 1, and then at cycle 3 prior to surgery. And this was purely exploratory. We know that the study was a positive study. And from the point of the OS, we know that immunotherapy addition had a decrease in the ctDNA, and this also had a prognostic impact. We also know that irrespective of whether the patient received immunotherapy or only chemotherapy, the one that did not clear the ctDNA did not do well. So again, this was exploratory. Here the intention and the final conclusion that it was a prognostic, it's not predictive of anything else. The Niagara study, I think, has been debated consistently since yesterday.
Nilesh, in the ctDNA negative, say you have gone a perioperative in SCLC and ctDNA negative at the time of surgery, would you give actual?
So as per the trial, no. In this trial, no.
In perioperative, I'm saying, assuming that you get a ctDNA negative at the just before the surgery.
Oh, I would continue. As of
You
now,
would
I would continue because I don't think those endpoints have been assessed in this trial at all. So in the Niagara study, again, here we use the Signatera at baseline, at the completion of chemotherapy, that is pre-surgery and then post-surgery. And here we know that neoadjuvant treatment, irrespective of whether it was the addition of IO or the cystectomy, both of these reduce ctDNA positivity. And we also know that the EFS was very well correlated with ctDNA clearance. Again, in this study, so far the conclusion is that it is prognostic. We have not made any changes based on ctDNA low or high. And for that, we actually have several more studies. We have the IMVIGA 1011 as well as the modern study where there is dose escalation being done. Now that's a matter of time. And again, a question here, how many of us in MIBC would consider using ctDNA to prognosticate or to consider treatment? I'm serious. I mean, that's the whole point of discussing something like this. And I'm seeing this being done in private.
No, I do a lot of ctDNA, but I have not started doing in bladder. Point is little afraid. Bladder is a difficult disease. Once it relapses, we all know that patients. There is no second thought about it. Till the time we have some more data, I'm little afraid in bladder that to stop the treatment if the ctDNA is negative, and this was a tumor informed. You take the cystectomy specimen and do all that. I don't think we are there as yet about the validation of the test in Indian labs and Indian population. So I would wait.
So you would also wait for data to come up from the modern trial and other trials. We discussed the dynamic study, and I don't think I'm going to go into this. We are very clear that at least for the dynamic in stage 2, many of us are doing this in practice. Anybody not using this test in practice? For dynamic stage 2. Who's not doing it? I know everyone's doing it. Who's not doing it? And if you're doing it, which test are you using? Are you only using Signatera? What are you using? Amish, what are you using? Amish, what are you doing? Anand, what are you doing? Sachin?
Affordable Signatera, non-affordable, because GeneTech guys have some data.
But is that test a tumor informed or tumor agnostic?
No, it is tumor agnostic.
So
I don't think in any Indian lab is doing tumor informed. I could be corrected. Yeah.
Yeah. So currently, I think so. One Cell Lab is giving MR. It's almost a year now. Yeah. They're doing the combo ctDNA CTC test called OncoMonitor. I've almost had 20 patients on that. The reliance is an issue. If it's negative, patients have relapse. If it's positive, abhi tak patient ko relapse nahi aaya. So that's a separate story. Signatera is available in India, and Guardant Reveal is also available in India. Guardant is half the cost in India as compared to Signatera. So that's just point.
So you get three tests in Guardant combined in one. That's how it happens.
My
question
now it's
is,
two
what are the time points that you do it? Because in the study, it was at week 4, week 8, and then at end of adjuvant therapy.
So for dynamic study, because remember this was 22 publication they did in 2020-21. The test was not evolved. So they were worried about taking decision on one answer. So they said, dono negative chahiye. Week 4 and week 7, then I'll take it as negative. And still they were wrong in around 6%, what Nikhil sir showed. The newer probes and the newer tech, which has internal validation, so Guardant Reveal only does one, between 4 to 8 weeks. So that's the MRD window.
Okay.
So
based on
you asked me, I do Signatera, Guardant Reveal and Datar I have been using. My only point is that there were 3 back-to-back patients, stage 2 ctDNA negative. I did not offer chemotherapy. And they went for second opinion and they were told that nahi, ye to bahut naya test hai aur aap chemotherapy lo. So as we discussed in panel, it is one of the factor. If there are no other high risk factors, then ctDNA negative, it gives you more confidence that yes, it is there. But my point is if it is T4N0 disease, ctDNA negative, and there is no other high risk factor.
So the reason of asking this question was, these are practical problems. So I had 2 patients actually, both colons, both with new lung nodules that came up on follow-up, and classical metastasis. You wouldn't say they're non-metastatic. In one, the ctDNA was negative, in one, it was positive. Both underwent resection, both turned out to be inflammatory tissue without any evidence of malignancy. So the reason I'm bringing this out is, while on a clinical trial we do it systematically, I think there are a lot of caveats that doesn't discourage us from doing this, but we need to learn from our lessons. I'll just come to the last issue about what I feel are the important things. We are still not very clear about which assay to use, whether we are going to use a tumor-informed versus tumor-agnostic. I think we've discussed very well. Anant has said that we should start believing in our own and probably have more experience with them, and that's one way, because it's unlikely that we are going to get clinical validation studies down the line for these studies. Tumor burst, side shedding, I'm not going to come to that, we mentioned, but we know that peritoneal and lung don't shed as much as, say, liver metastasis. What about the duration and timing? It varies from disease to disease. So in some you're doing it pre-surgery, some post-surgery, some at baseline. I think you have to either follow it the way that it was done in the original trial. It's very difficult to pick and choose timings for different patients in different case scenarios. Cost-effective access and compliance, we've not discussed compliance. I mean, we're talking about compliance issues with letrozole. Imagine doing a test every 2 months for 2 years for patients. And the anxiety. One of the biggest problems both these patients faced, and why I actually went for surgery in their case, is because they were going berserk with that ctDNA level going high. And it's been an experience with others also. I mean, you get anxiety with PET scan every 6 months or every 2 years. Imagine doing a 2-monthly tumor DNA assay. Unless we are a lot more confident about what the result is going to be, pushing an assay in every patient is probably not the way to go. And the third thing is, are we just buying into lead time bias? I mean, for lung, it may be 3 months. For her HR positive breast cancer without non-ESR mutated, it can be as high as 69 months. So deciding all our treatment just based on this is probably incorrect. Most of the studies today have been observational. The next generation of studies are actually all interventional. And unless that really comes up, as of today, it's going to be just data for dynamic, not so much for the others. Anybody has a difference of opinion? Amish, you have to say something.
I'm going to say. It is excellent.
Chala, thank you so much.
I was just wondering, Nilesh, why do you say no for speeches and moderation when you speak so well and so crystal clear? I think summary was very good. For summary, Mumbaikars have scored over. Yesterday, Prabhat's summary was excellent, and today Nilesh's summary was also very good and to the point. please.
So the last session was a very interesting one. I think Dr. Anbarasan as well as Dr. Nikhil and the whole panel really brought out all the finer points that were required with regards to ctDNA discussion. And honestly, in the last 2 days, I think most of this conference has been more about ctDNA rather than anything else, although I'm not very sure whether we are really wiser at the end of all this. So just to go through, we first had the Serena-6 study, metastatic MBC patients who had an ESR1 mutation that were detected. Out of 3,300 had this. These were then randomized to receive camizestrant as opposed to continuing the same line of therapy. What is important here is that the ctDNA was done by the Guardant 360, and that was done every 2 months till the end of therapy, and then one more after that. So given a median of 16 months, we are talking about 8, 10, 15, and 20 tests that is done over a period of time. The logistics of that is very important. And what this showed, yes, it was a positive study with a good improvement in the PFS. And this study basically concluded that the primary endpoint, that was PFS, was met. Several secondary endpoints were met, the PFS2, as well as the chemotherapy-free interval. It also showed a significant reduction in the ESR1 mutant allele frequency in patients who received the new drug. And it has basically demonstrated the clinical, that ctDNA monitoring to detect and treat emerging resistance is possible. We've already discussed many of the lacuna in this study, most the crossover, which was not there. And therefore, while this is a very interesting concept and is most likely going to go forward, until we have some OS data, we are not really going to be accepting this. At least that's what is for me. Is anybody here ready for this on Monday morning, assuming the drug is here? No, it is in the situation that it is. Absolutely no. What about with that data? No, what about that data which says that the earlier you use something for ESR1 mutant, it's always better. Response rates are higher and PFS is better. Yes. No, not yet. No. The study was the second was the CheckMate 816, and what I'm going to highlight here is just that the points when the testing was done. So here, the ctDNA testing was done at baseline, that is prior to cycle 1, and then at cycle 3 prior to surgery. And this was purely exploratory. We know that the study was a positive study. And from the point of the OS, we know that immunotherapy addition had a decrease in the ctDNA, and this also had a prognostic impact. We also know that irrespective of whether the patient received immunotherapy or only chemotherapy, the one that did not clear the ctDNA did not do well. So again, this was exploratory. Here the intention and the final conclusion that it was a prognostic, it's not predictive of anything else. The Niagara study, I think, has been debated consistently since yesterday.
Nilesh, in the ctDNA negative, say you have gone a perioperative in SCLC and ctDNA negative at the time of surgery, would you give adjuvant?
So as per the trial, no. In this trial, no.
In perioperative, I'm saying, assuming that you get a ctDNA negative at the just before the surgery.
Oh, I would continue. As of now, I would continue because I don't think those endpoints have been assessed in this trial at all. So in the Niagara study, again, here we use the Signatera at baseline, at the completion of chemotherapy, that is pre-surgery, and then post-surgery. And here we know that neoadjuvant treatment, irrespective of whether it was the addition of IO or the cystectomy, both of these reduce ctDNA positivity. And we also know that the EFS was very well correlated with ctDNA clearance. Again, in this study, so far the conclusion is that it is prognostic. We have not made any changes based on ctDNA low or high. And for that, we actually have several more studies. We have the IMVigor 1011, as well as the modern study where there is dose escalation being done. Now, that's a matter of time. And again, a question here, how many of us in MIBC would consider using ctDNA to prognosticate or to consider treatment? I'm serious. I mean, that's the whole point of discussing something like this. And I'm seeing this being done in private.
No, I do a lot of ctDNA, but I have not started doing in bladder. Point is little afraid. If you bladder is a difficult disease. Once it relapses, we all know that patients.
There's no second
There
line.
is no second thought about it. Till the time we have some more data, I'm little afraid in bladder that to stop the treatment if the ctDNA is negative, and this was a tumor informed. You take the cystectomy
Yeah, this was
specimen and
Signatera,
do all
correct,
that.
Signatera.
I don't think we are there as yet about the validation of the test in one Indian labs and Indian population.
So,
I would wait.
So you would also wait for data to come up from the modern trial and other trials. We discussed the dynamic study, and I don't think I'm going to go into this. We are very clear that at least for the dynamic, in stage 2, many of us are doing this in practice. Anybody not using this test in practice? For dynamic, stage 2. Who's not doing it? I know everyone's doing it. Who's not doing it? And if you're doing it, which test are you using? Are you only using Signatera? What are you using? Amish, what are you using? Amish, what are you doing? Anand, what are you doing? Sachin? But is that test a tumor informed or
No,
tumor
no, no, no.
agnostic?
It is tumor agnostic.
So you
I
have
don't
a-
think in any Indian lab is doing tumor informed. I could be corrected. Yeah.
Yeah, so currently, I think so One Cell Lab is giving
started doing
MR. It's almost a year now. They're doing the combo ctDNA CTC test called Onco Monitor. I've almost had 20 patients on that. The reliance is an issue. If it's negative, patients have relapse. If it's positive, abhi tak patient ko relapse nahi aaya. So that's a separate story. Signatra is available in India, and Guardant Reveal is also available in India. Guardant is half the cost in India as compared to Signatra. So that's just point.
So you get three tests in Garden combined in one. That's how it happens.
So
My
now
question
it's
is,
two
what are
tests.
the time points that you do it? Because in the study,
So
it was at week 4, week 8, and then at end of adjuvant therapy.
So for dynamic study, because remember this was 22 publication, they did in 2020-21, the test was not evolved. So they were worried about taking decision on one answer. So they said, dono negative chahiye, week 4 and week 7, then I'll take it as negative, and still they were wrong in around 6%, what Nikhil sir showed. The newer probes and the newer tech, which has internal validation, so Guardant Reveal only does one, between 4 to 8 weeks. So that's the MRD window.
So
Based on
you
Pegasus.
asked me, I do Signatra, Guardant Reveal and Datar I have been using. My only point is that there were 3 back-to-back patients, stage 2 ctDNA negative. I did not offer chemotherapy, and they went for second opinion, and they were told that nahi, ye to bahut naya test hai, aur aap chemotherapy lo. So as we discussed in panel, it is one of the factor. If there are no other high-risk factors, then ctDNA negative, it gives you more confidence that yes, it is there. But my point is, if it is T4N0 disease, ctDNA negative, and there is no other high-risk factor.
So the reason of asking this question was, these are practical problems. So I had 2 patients actually, both colons, both with new lung nodules that came up on follow-up, and classical metastasis. You wouldn't say they're non-metastatic. In one, the ctDNA was negative. In one, it was positive. Both underwent resection. Both turned out to be inflammatory tissue without any evidence of malignancy. So the reason I'm bringing this out is, while on a clinical trial we do it systematically, I think there are a lot of caveats that doesn't discourage us from doing this, but we need to learn from our lessons. I'll just come to the last issue about what I feel are the important things. We are still not very clear about which assay to use, whether we are going to use a tumor-informed versus tumor-agnostic. I think we've discussed very well. Anand has said that we should start believing in our own and probably have more experience with them. And that's one way, because it's unlikely that we are going to get clinical validation studies down the line for these studies. Tumor burst, side shedding, I'm not going to come to that, we mentioned, but we know that peritoneal and lung don't shed as much as, say, liver metastasis. What about the duration and timing? It varies from disease to disease. So in some you're doing it pre-surgery, some post-surgery, some at baseline. I think you have to either follow it the way that it was done in the original trial. It's very difficult to pick and choose timings for different patients in different case scenarios. Cost-effective access and compliance, we've not discussed compliance. I mean, we're talking about compliance issues with letrozole. Imagine doing a test every 2 months for 2 years for patients. And the anxiety. one of the biggest problems both these patients faced, and why I actually went for surgery in their case, is because they were going berserk with that ctDNA level going high. And it's been an experience with others also. I mean, you get anxiety with PET scan every 6 months or every 2 years. Imagine doing a 2-monthly tumor DNA assay. Unless we are a lot more confident about what the result is going to be, pushing an assay in every patient is probably not the way to go. And the third thing is, are we just buying into lead time bias? I mean, for lung, it may be 3 months. For her HR positive breast cancer without non-ESR mutated, it can be as high as 69 months. So deciding all our treatment just based on this is probably incorrect. Most of the studies today have been observational. The next generation of studies are actually all interventional. And unless that really comes up, as of today, it's going to be just data for dynamic, not so much for the others.